Well, it's almost 1 o'clock, and I think many of you can hear me, and so I'll at least begin welcoming you all to join me in this. As you can see, I'm in scrubs. I've been in the operating room already this morning, and I'll be heading back after this kind of presentation. And there is the question bar, so if anybody has any questions, we'll try to answer those as we go through. Or if anybody wants to chat or anything. And really right at a little bit after 1, I'll start and at least update everybody about what's going on, at least here in Cleveland, and what you could possibly do at your facility also. Let me know if anybody has any questions throughout this, and we'll kind of open up for chat, or my email will be at the end of this presentation. I'm sure you can get my email if anybody would like it. Well, it's 1 o'clock here in Cleveland, and I'm going to go ahead and get started. I welcome you all for being here. If you have any questions, please try to use the question and answer or the interactive nature of this. Unfortunately, I can't hear your questions. I'll try to answer the questions if I see that. I think somebody from Synapse might also be able to let me know if there's any questions. It's been very hectic, as you all know, the last several months with the pandemic. As you can see, I'm in my scrubs. I actually have 2 patients getting the TransAeris device presently in our operating room with our liver transplant team and one of our cardiac surgeons. So I'm going to talk a little bit about our new temporary device, along with going over some of our data that we have with over 20 years of pacing the diaphragm to help patients breathe. So again, I'm at University Hospitals Cleveland Medical Center, where I've been for almost over 2 decades now. In full conflict of disclosure, what you're going to see here was developed at Case Western Reserve University, University Hospital Cleveland, and myself. I'm involved with Synapse Biomedical. No other investigators have had a conflict of interest. I will be discussing some off-label use of FDA-approved devices prior to the FDA emergency use authorization of the device also. So with that, I'll start talking a little bit about what really has been my career with this. And we really know the problem that we all face right now throughout the world, both now and in the future, is the lack of ventilators. In the United States, prior to this pandemic, we knew that over 100,000 tracheostomies were done for failure to wean. All of us knew that our ICUs were not empty prior to this pandemic. We know that we've had problems in weaning patients off of mechanical ventilation. We know that after your acute event, it could be a pneumonia, it could be a salvage operation. After that acute event, 40% of your time that you're on the ventilator is just rehabilitating your diaphragm, addressing ventilator-induced diaphragm dysfunction. So we know that ventilator-induced diaphragm dysfunction is a cause for part of our weaning problems. Diaphragm pacing does not help with oxygenation. Diaphragm pacing helps with ventilation and maintaining that muscle mass. So when your acute event is over, you will have your diaphragm ready to get off that ventilator. We know when you're on that ventilator that you'll get 50% atrophy of your diaphragm within 24 hours. We know that that muscle, which is usually a slow twitch muscle fiber, will convert to type 2B muscle fiber fast twitch almost immediately while you're on the ventilator. We know, and modeling what's occurring with the COVID pandemic, that about 30% of hospitalized COVID-19 patients will require the intensive care unit. We know right now our concern is tracheostomy. We know that tracheostomies, even for our other patients, are being delayed because of that risk of possible virus spreading with the tracheostomy. We know that risk of COVID exposure during that tracheostomy. So if we could wean a patient without a tracheostomy, both our COVID patients or other patients that we're all seeing in our practice, that would be a tremendous benefit. One, to get the patient off the ventilator and decrease our exposure, our surrounding helpers' exposure to the COVID virus. So part of the solution of this lack of ventilators is to maintain diaphragm strength and really drive respiration with diaphragm pacing. We've shown in all of our previous work, and we've been working on this for 20 years, that we can decrease that 40% of time by about 60% of the time by maintaining diaphragm strength. So once that acute event is over, the diaphragm is strong and ready to start weaning the patient off the ventilator, ready to take that next step. The FDA recognized this, and literally 9 days ago, the FDA gave emergency use authorization for the TransAeris system. The TransAeris system is a system that we've been working on for several years. It's a temporary and disposable version of the chronic system, for which we have 2 decades of experience with. It will decrease the ventilator needs and also would allow the ventilator to be used for other patients. So we can use it for ventilator weaning and actually decrease the need for ventilators. I'll kind of fairly briefly, and hopefully I won't talk too fast, outline some of our success so far. In background, this is, again, something I've been working on for over 20 years. We've done various animal models from canines, swines, and rats. In my own institution, I have 14 different IRB protocols and IDE protocols. Over the 20 years, $60 million has been spent on this project. With the diaphragm pacing technology, over 2,000 patients have been implanted worldwide, 28 countries. At my own institution, over 700 patients have been implanted. Again, my entire academic career with over 50 peer-reviewed publications on this technology has been done. So my objective briefly this afternoon is to outline the success of our chronic system, the NeuroRx system, the decreased ventilator use for spinal cord injured patients, which is still available and works very well, and kind of review our surgical implantation of the TransAeris device. I'll discuss how the use of the authorized use of TransAeris will help decrease mechanical ventilation. We have data that we've already used. I own a case example just last week. I really look at 3 areas: trauma or emergency abdominal surgery, cardiac surgery, and really medical intensive care unit patients, the ones that we would get consulted for tracheostomies. And again, as we look at the utilization of our COVID-19 patients, I'll talk about that briefly at the end. It really started with spinal cord injury. The first implant was 20 years ago. What we know is that if you have a spinal cord injury, many patients require intubation and mechanical ventilation. 20% of all cervical injuries require tracheostomies. 50% of them will be on mechanical ventilation when they're discharged from the hospital. We know that if you're on mechanical ventilation, you're at a much higher risk for a pneumonia. We know that mechanical ventilation significantly contributes to the hospital costs. We know it decreases life expectancy. I'll kind of show you some of our data on what we can show in this regard. We know in our experience that 100% of patients that have intact phrenic nerves, we can actually pace their diaphragm and get them off the ventilator. There's not a single patient that I've ever implanted that says, you know, I like tracheostomy ventilation as opposed to a diaphragm pacing. And then, unfortunately, my second patient I ever implanted was Superman, and we did quite well in helping him get off the ventilator. And again, this is a standard laparoscopic operation. As you can see up in your left-hand corner, standard laparoscopy. We implant 2 electrodes at each diaphragm with a special implant tool. You'll see our newer TransAeris system uses a much easier electrode to put into the diaphragm. Then we can kind of check the diaphragm for contractions. This is while the patient's not paralyzed in a spinal cord injured patient. For most of other patients, we don't need to utilize that. We know that this device is an external device. It can be used for up to 20 years on our earliest patients. We can program the device. You'll see in our newer device, we don't need all this extra programming stations. We can just do it right with the device itself for temporary use in your intensive care unit. And again, outlining our success, we know on some of our data that we've been very successful. This is a summary of my data on 92 patients I published in 2018, that we were successful in getting patients off the ventilator 88% of the time. 60%, 24 hours, not using a ventilator at all. In this group of patients, we're implanting patients up to 25 years after injury. When we implant patients very quickly, we get them off the ventilator very rapidly. I'll share with you some of that data. This is an example of this. This is something you may see right now. A patient who is acutely injured, spinal cord injury, is a high school wrestler, injured his neck. For 21 days, he was trying to wean off the ventilator. He was transferred to my institution, and literally we implanted him, and 2 days later, we extubated him without a tracheostomy, which, as you can imagine, in this day and age, I could have implanted him at day 3 or 4 and saved 21 days of being on the ventilator. Again, his rehabilitation as a spinal cord injured patient, once he's off the ventilator, is significantly improved. This is some of our earlier work, multi-center, 10 sites. Again, 73% of these patients were able to be weaned off the ventilator just 10 days after implantation of the diaphragm pacing. In a second, I'll share with you some of our newer data from Dr. Kerwin in Florida, where he's shown that you can decrease this time on average from 30 days to just 10 days after your injury. That's a significant improvement, significant saving of ventilator days, opening up ventilators for other patients in our ICU. And this is what he had shown in some of his early data. His first presentation, he showed he changed the mortality rate from 33% death rate with diaphragm pacing. Previously, it was 15%. So once you can get that patient off a ventilator, it changes their survival, which is critical for a spinal cord injured patient. I've talked to spinal cord injured patients with this pandemic, and they're worried that they'll come into the emergency room and there's a shortage of ventilators, and they may be told that you have no life to live because they're on that ventilator. And these patients, if we offer them diaphragm pacing, we can get them off the ventilator and make sure that they can live their life. And most spinal cord injured patients have an excellent ability to live their life again once they get off that ventilator. And we can offer that to these patients, both with our newer device or even our older device. Getting off the ventilator is critically important for these trauma spinal cord injured patients that come into your hospital. And he had shown this at a recent presentation just last year, that the time to ventilator liberation with diaphragm pacing was only 10 days. Without it was 30 days. And again, his conclusion was comprehensive care of the acute spinal cord injured patient should include diaphragm pacing. This has been around, we have that capabilities. And really now with the TransAeris, you could utilize it in patients that you think you might wean, they just need a little bit more. That TransAeris can be easily implanted and then utilized to help these patients in their early stay in your intensive care unit. We've shown in some other work that, again, as we all know, once you have mechanical ventilation, you get posterior lobe collapse, that you have problems with that. We know that most spinal cord injured patients coming to your trauma hospital, as the Western Trauma Association showed, can have a ventilator-associated pneumonia. It's a right lower lobe collapse. This patient had a non-functioning right diaphragm. We were able to correct that with diaphragm pacing. That's one of the benefits of diaphragm pacing, is that we can correct an abnormal control of the diaphragm and prevent that atelectasis and the problems. And I'll show you a case that we just utilized the TransAeris on yesterday with this exact problem of an abnormal diaphragm on one side while undergoing another emergency operation. Why would we use temporary diaphragm pacing? This goes back to the New England Journal article in 2008 that showed how rapidly the diaphragm atrophies. Since then, multiple studies have shown that. We all accept the fact that if you're not using your diaphragm on the ventilator, it will atrophy. And that atrophy is what we need to reverse when we start weaning a patient. We know that there's over 100,000 temporary tracheostomies are performed. We know that tracheostomies have significant complication risk. Prior to the pandemic, we know that there's about $64 billion spent on failure to wean and the prolonged mechanical ventilations in the United States. And now that both myself and our ENT were kind of delaying the tracheostomies for many patients because of the fear of the risk of transmitting COVID on these patients, that if we can prevent a tracheostomy, it's great for the patients and it's great for all of us. So we have that opportunity with the TransAeris system. We had been looking at this type of data over the last several years. This is an article that we presented several years ago showing that, as you can see in this diagram here, median sternotomy, temporary wires. This is our initial pilot trial showing that we could implant these electrodes during an operation without the mapping of our chronic system, that we could actually maintain tidal volume by just placing these electrodes 137% of predicted for these patients. We confirmed that we can implant this successfully during a laparotomy, during a laparoscopy, and during a median sternotomy. The conclusion of this article again shows ease of placement, the removal, safe removal of these electrodes, and that we could actually help maintain diaphragm function during that time period. Again, laparoscopically, it's a standard exposure of the diaphragm. This is the patient's right diaphragm. So now much easier electrode with a needle on the end. We can pull that electrode into the diaphragm. And the aspect for this is that we don't need to use the tunneling system of our old system. We just bring the electrodes out directly from the abdomen. So suturing the electrode onto the diaphragm is pretty much a straightforward laparoscopic procedure. We can then use a suture grabber, such as Carter-Thompson, or the Keith needle on these electrodes to bring them out. We then just suture the electrodes on the outside the abdomen, and then we can hook it up to our external device. So again, it's a standard laparoscopic procedure. It can be done with paralytics now, since we don't need to map the diaphragm. It can be done fairly easily. Now I'll show you an example of a patient just last week. This is a patient who had been in Columbus, Ohio. I'm in Cleveland, Ohio. Had tracheostomy, ventilator dependent for 30 days, failure to wean. He presented with severe bilateral diaphragm dysfunction. PCO2 on admission was 90. They realized that neither diaphragm was working. We were able to retrospectively look at his chest x-rays from before. He had a previous cardiac procedure with an injury to his right phrenic nerve with elevated right diaphragm. He then developed idiopathic diaphragm dysfunction on his left side. He had a tracheostomy on March 16th, 2020, unable to wean. He was sitting in the hospital, able to walk around, but we had no home ventilators in Ohio for him. So he was in a hospital with nothing to do because there's no ventilators. Worried about getting COVID-19, being in the hospital with this. Fortunately, in Ohio, we've not had a huge problem with COVID patients, but he was transferred to my facility. And on Monday, April 13th, I implanted him. 2 days later, I removed his tracheostomy. So 2 days of diaphragm pacing completely changed this man's outlook. His PCO2 while trying to wean with his tracheostomy and pressure support was 56. On that Wednesday afternoon, after pacing all day, his PCO2 was 43 and his tracheostomy was removed. So that shows what we can do by just driving that diaphragm for somebody that doesn't have control of that diaphragm. It will really change what's occurring for these patients. And again, this just shows his x-ray. Not much lung volume here. Tracheostomy, several days later, no tracheostomy, much greater lung volumes, breathing on his own. That's what we can do for these patients. So for this patient himself, it allowed him to leave the hospital, leave the intensive care unit, and go home. He went home with just CPAP and BiPAP for backup, basically, and pacing 24 hours a day. We had previously looked at this, and we presented this at the ATS meeting last year. We had several presentations at the ATS meeting this year, and as we all know, all medical conferences are being canceled. We had shown in a group of both medical and surgical ICU patients, 22 patients that we could wean them off with using off-label use of our chronic system on these patients. And so we had a very good success on these patients in our intensive care units, on average being on ventilators for our 60 days in our surgical patients, over 100 days in our medical patients, and using diaphragm pacing to drive the respirations, rehabilitate their diaphragms, allowing them to be freed from the ventilator in a high proportion of these patients. Again, we had shown in our initial pilot trial that during major abdominal operations, again, this as a general surgeon, this is the case that we know will have respiratory problems on, fixing that. Postoperatively, again, you can see our standard drains, and this is just having the pacing wires placed, the ability to control the diaphragm if needed on these patients. And here's a patient that we did this on yesterday. Again, with the FDA emergency use implantation, this is a patient who had a very complex aortic reconstruction for renal, AAA, with a history of aortic dissection and Marfan syndrome. We had, I think, 3 previous operations for this. He had a complex operation for this large infrarenal aneurysm. As you can see on his chest x-ray, after that, he's intubated, elevated right diaphragm, which he had prior to this somewhat urgent operation. And he was going back in for that second look at 48 hours. So at that operation, we were able to place these electrodes. So you can see the electrodes on his right diaphragm. I'm looking from the head of anesthesia, open abdomen. He then subsequently went to component separation. The electrodes were being placed. This is the electrodes being placed on his left diaphragm. We bring them out through the abdominal wall above where we planned for the component separation. And then we kind of watched him. We had these electrodes in thinking he'd be a difficult weaning, and he was. In our ICU where he was at, he was having significant problems with respiration. His PCO2 was 64. You could see he was on BiPAP to try to help. His tidal volume was just 50. He was kind of driving it. And we just turned on the pacer. His tidal volume went up, PCO2 went down. We saved him from the possibility for reintubation because we could help drive his diaphragm. We know patients with a unilateral elevated diaphragm have episodes of significant sleep apneas because of that abnormality of his breathing. And obviously in the immediate postoperative care, with sedation on board, he was not breathing well. So we were able to extubate him with the pacer and using BiPAP to maintain it. And this is an example of the on-off capabilities. We prevent the paradoxical movement of that right diaphragm, increases tidal volume significantly, and allows carbon dioxide level to go down because we're improving his ventilation. And again, this was just yesterday with FDA approval. We were able to place this during that laparotomy, component separation, and a high-risk surgical patient for a second look operation and allow him not to be reintubated. Allow and decrease that risk for having a tracheostomy if we have problems weaning him by having those electrodes in. We've also done work in our initial pilot trial showing in a median sternotomy that we could place these electrodes. And again, I'll show you some of our examples. We've really been utilized this in our high-risk cardiac patients over the last week. And this will show a video of, again, this is an open heart operation, high-risk cardiac procedure being done last week, median sternotomy. This is the right diaphragm. You can see the diaphragm very well in median sternotomy. This is actually the cardiac fellow placing these electrodes fairly easily. Again, it's just like putting in temporary cardiac pacing electrodes. You can bring the electrode out. You can cut off the needle that we have. You then pull the electrode back in to the diaphragm. You can see a nice bypass graft on the heart there. We have Keith needles where you can just bring it out, very similar to temporary cardiac. The same thing that we did with the laparotomy yesterday. And the electrodes can be removed. We've already shown that we can safely remove it. The Keith needles are cut, and we just suture them like standard temporary cardiac pacing wires onto the abdomen, or upper chest in this case. And then again, you can see the video of the patient's left diaphragm. Again, you have a nice visualization of the diaphragm. See the electrode going into the diaphragm, pulling out the electrode, then pulling the polypropylene core of our electrode. On the second electrode, we place 2 electrodes in each diaphragm. Again, we always say with a pandemic or other problems, you can very rapidly learn to do new procedures to help patients. And I'll show you what we were able to do on this patient. Again, this is the TransAeris unit. This was a interesting patient. He was on the list for liver transplant. He had a critical coronary that could only be done on bypass, could not be done percutaneously. And so he went on off-pump cabbage. He went encephalopathic afterwards. And so we're driving his ventilation while waiting for the liver transplant. And you can see on this picture over here, this is a gentleman who's only on CPAP. The diaphragm pacing unit's at 18. We're ventilating him at 10 liters per minute, purely by the pacer. So this patient has maintaining negative chest pressure, basically. He's not on volume ventilation. If I would turn off this pacer with his encephalopathy, his ventilatory rate would go to 4 breaths a minute. So we're able to maintain this on him until he gets his liver transplant, which he actually got Monday. And so he was just on the pacer for 10 days with pressure support, maintaining his failing liver until he was eligible for that liver transplant, which got on Monday of this past week. We know in cardiac patients how important this is, the decreased prolonged mechanical ventilation. We know overall, a cardiac patient is on a ventilator at 72 hours, the risk for morbidity and mortality goes significantly up. The risk for infection goes up. The problems develop. The cost goes up. We know that 12% of all cardiac cases require mechanical ventilation after 24 hours, and roughly 4% of those require it at 5 days. What we look at in this cardiac population is the ways to actually decrease this problem. We had actually looked at this previously on postoperative patients who could not be weaned. I presented this at the STS meeting 2 years ago. We were able to get 6 tracheostomy patients decannulated. We were able to use the electrodes to monitor recovery. We showed a significant, listen to small pilot trial, improvement in survival. We know a tracheostomy in a cardiac patient has a significant mortality rate of about 50%. At least in this group of patients, we had 80% 1-year survival rate in a small group of these patients we're looking at. We expanded this study recently, and I presented it at the 32nd Annual Congress in Berlin just in the fall, where we had a total of 23 patients now. And 20 of these 23 patients were able to help recovery of an injured phrenic nerve at the cardiac operation. This allows complete weaning of these patients very rapidly. So we've shown, and this technology can help cardiac patients significantly. Here's an example of a patient with a bilateral diaphragm dysfunction after a left ventricular assist device. Again, it's hard to go for a heart transplant if you have tracheostomy mechanical ventilation. We implanted him, got recovery. You can see the improvement of his lung volumes at a simple chest x-ray. And he was now eligible for a heart transplant because he was no longer on mechanical ventilation. And I'd like to say this is our chronic system, this left ventricular assist device, and our chronic system that the only system we had available in the past. We had previously shown in Europe that the TransAeris system has value. It's been utilized in Europe, in Murnau, Germany, in Milan, in Madrid they were going to start. This is a group that was looking at this system during lung transplants in Leuven, Belgium. This is their publication showing that one, they place it in lung transplant patients, that can help show the safety of the implantation, that can trigger the ventilator. And presently in our ICU, we had 2 lung transplants over the weekend that we actually utilized this device, the TransAeris system, because the ability to actually monitor. And one of those patients has significant sleep apnea, and we're pacing that patient after the lung transplant. That patient otherwise would have had to stay on positive pressure mechanical ventilation or significant BiPAP. Instead, we're just pacing the diaphragm until he recovers from his lung transplant. So we've been able to use this TransAeris system really rapidly in our quaternary care hospital at University Hospital's Cleveland Medical Center. Overall, we think we're going to change the paradigm in the intensive care unit. We think we can overcome ventilator-induced diaphragm dysfunction, and really it's a therapy for respiratory insufficiency and arrest. We've done a lot of work on that. We can maintain negative chest pressure, which is important to increase cardiac output. We can reduce airway pressure. We can increase diaphragm strengthening, posterior lobe ventilation, and we have this opportunity now. I've also looked at what we're going to do in our COVID population. As we all know, unfortunately, patients that get intubated with COVID-19 have a significant mortality rate. Presently at our center and other centers I've been talking to, we know there's certain patients that will survive that. We know we're delaying tracheostomies for these patients up to 4 weeks now because of the risk of it. Our own protocol that we are presently going to use for our COVID-19 patients that may need this is 1, to recover from their acute ARDS type symptoms. 2, hopefully they'll become COVID negative during this time period, which could be 2 to 3 weeks. We then assess for their ability for weaning based on looking at their diaphragm function. So we're doing some ultrasounds to see if they have diaphragm movement, to see if they can control their diaphragm. If they can't, or we think it's going to be a prolonged wean, we would add diaphragm pacing before the tracheostomy. 1, it would decrease the risk for tracheostomy in these patients. Laparoscopy, most of us would feel is less risky than doing a tracheostomy for these patients. If we can decrease the risk for tracheostomy, that would be of value. Unfortunately, as we all know, the survival rate for patients that become intubated in ARS is pretty poor, with probably only a 20% survival rate. So can we, after that initial disease process, before we do the tracheostomy on a certain subgroup of patients, can we help wean them at that point in time? That's a protocol I'll be using for our COVID-19 patients here in Cleveland. Fortunately, we have not had a huge problem in our intensive care unit. What we found with this TransAeris is we can open up ICU beds by utilizing it for our other patients. They become a very good tool as we assess patients. I think our most common indications would be for any spinal cord injury patient that comes into your hospital. The data is very strong. To not do a tracheostomy, get them off the ventilator much early is significant for these patients. We know that community is worried about not having ventilators for themselves. We know that high-risk surgical patients, especially patients undergoing high-risk cardiac procedures, can have these temporary electrodes placed at the time of their median sternotomies or their laparotomies. I think for trauma surgeons, if we have that take-back patient that we can predict will have problems, it's very easy to place the electrodes. The benefit is, if the patient does well for weaning, you can pull the electrodes. If the patient has a problem, you now have control of their diaphragm to prevent that atrophy for these patients. Any patient being considered for a tracheostomy in our medical intensive care unit should be evaluated for this. Again, the goal for diaphragm pacing is to drive ventilation. That's what we're doing. If it's an oxygenation problem, that's going to be something separate. I'm going to try to check to see what questions we may have. And this is kind of what I like to say is if we can move that diaphragm, we can help wean patients off the ventilator. And that's what we're trying to do with the ability for the TransAeris to drive that ventilation for patients. So a question I got is, are you not implanting this device in COVID-19 patients? In Cleveland right now, our COVID population on intensive care unit has been really small, fortunately. So we've not had that opportunity. Obviously, in our institution where we have such great experience with this, our intensivists are all familiar with it. And what we're identifying is that the patients who may or may not be able to implant, we'll address. We'll see what happens. Again, we only had this over the last 1 week, the ability to put it in these COVID patients. We'll see what occurs. The key aspect for this is that we don't need the map. The operation is a little bit easier. Another question that came through is, what is the risk of infection? This is a percutaneous device. We've had patients with this device in our spinal cord for over 15 years. We can actually show that these electrodes for patients that use it in spinal cord injury for years don't get infected. I've actually, in our ICU, because of our experience, I've actually done diverting colostomies and placed these electrodes at the same time. There's another question from Florida, Dr. Lautenberg, who I've worked with for years in the past. Can we use it with pacemakers and AICDs? Yes, we can. We were able to, I think you're a co-author on a paper we had on cardiac pacemakers. We published that several years ago. Cardiac pacemakers can read our stimulation of the diaphragm. We had no interaction. We've done a lot more work with AICDs because most patients with left ventricular assist devices also have AICDs, and we've shown no interaction. We would check the AICD when we're pacing the diaphragm or the cardiac pacemaker after implantation to make sure we don't see that interaction. There's another question about concurrent infections. So I have placed this at the same time. One of the aspects we look at is that we can remove these electrodes. The double helix design of these electrodes, just they don't cause infection. So again, in my spinal cord injured patients, I've actually placed these electrodes and done a diverting colostomy on patients, which we know would be a clean contaminated. I've placed these electrodes on multiple patients at the time of their PEG tubes. So we do know that it does not cause a contamination with this. I think right now in our ICU, when we have an exploratory laparotomy for that unfortunate dead colon in our medical intensive care unit and somebody that's already on the ventilator, I would place it at that time period. We would watch for that, and we would hope that we would be able to wean that patient in 5 to 10 days, and we just pull these electrodes. The electrodes come out completely. We don't really have that risk of a retained foreign body in there for a long period of time. There's a question for reimbursement. For those surgeons out there, we do know there's a CPT code for putting in the electrodes. And actually, most of our ICUs, when we've talked to patients or institutions, is the reimbursement is by decreasing your ICU care. When we look at our cardiac patients, if you have a prolonged mechanical ventilation based on the DRG for open heart operations, it would be covered underneath that DRG. For our patients with spinal cord injured patients, we've always gotten reimbursement for putting in the much more expensive device for it. There's a nice question about hopefully that'll answer this question. It's hard to be, I can see another question here. The interesting is that no mapping is needed. And that's what we really proved in our pilot trial, is that we have a very good idea. If I'm going to use this not for chronic nature, I don't need to be exact on where this electrode goes. If I'm placing it for a spinal cord injured patient, I would like to map that because I'm going to control that ventilation for the rest of that patient's life. I want to get the best diaphragm contraction to give that patient the best tidal volume. In patients that have a normal system, what we found in our experience on these patients is that I can place these electrodes and I'm just driving ventilation. I like to think that our problems for weaning for these patients in the intensive care unit is their lack of respiratory drive. That lack of respiratory drive is what we're causing. I'm almost like the lateral medulla, the pre-sponsor complex with that electrode that you're placing. We're driving that patient to breathe. So I don't need to map the diaphragm. I'm just giving enough stimulation for the patient to breathe on their own and overcoming that lack of ventilatory drive that we all see for these patients. I can see somebody from University of Jackson has placed it in contamination and infection without problems, confirming what we've seen in our own practice here. There's a question about the difference between the chronic unit and this new TransAeris. Well, fortunately, they're both based on the science we've been doing for 20 years. We have such a great experience in how to get that diaphragm to contract. We've shown that we can overcome atrophy. We can take a patient on a ventilator for 10 years and rehabilitate their diaphragm and get that to work again. We've shown that that works quite well. And this system that we now have, it's just temporary. It's using the same technology with an electrode that we don't need to map the diaphragm. Simpler to place because we don't need this tunneling. The device that we utilize to pace the diaphragm is easier. You have control of pacing the patient. I'm going to get it. Again, in my office, we have devices everywhere. And so this is a device. So I can set the device at the patient's bedside. I don't need to program it. It's easy to utilize. And then the key aspect is you can pull the electrodes. Once you wean the patient, you can pull those electrodes. So the implantation technique is easier because it's on a needle as opposed to our chronic system. We have to use a special implant device. Dr. Kaufman, who's been very active, and again, I'm glad to see he's listing in on helping patients with no phrenic nerve. He's really one of the world's experts on phrenic nerve transfers and helping patients that don't have that area. And his question is, do these leads get pulled out completely versus cutting at the skin like the permanent system? These electrodes are not tunneled. We've shown in our trial that they don't get the tissue ingrowth. We've designed it different. And even in the last month that I've been placing a lot of these through a separate IDE trial, we can, I think just in the last week, I've pulled 20 electrodes in their entirety after the patient was weaned or didn't need them anymore. They can come out. There's no tunnel, there's less electrode in the body because the slack is all outside of the body. So we've been able to pull them all out completely on these cases. We've had no retained foreign body on these patients. Dr. Ducko from Boston asks, is the generator box usable like a temporary cardiac pacer box? This device is made for 30 days use. We were worried about, obviously, even the COVID pandemic and whether or not the contamination of this. So this is a one-time use. You use it for a single patient, and then you don't need to utilize it anymore. So you just throw it away. So it's a complete disposable device for these patients. This is a great question from Dr. Ducko. How's the IRB process to getting this lined up? This is actually FDA approved. It's no longer IRB dependent. What he asked for is our chronic system was, it wasn't required IRB. The FDA had a humanitarian device exemption for that. So it's a humanitarian use device for spinal cord injury because spinal cord injured patients are an orphan disease. So it required, based on the 1988 regulations for those devices, an IRB. The chronic system does not require any research. It's a way for the FDA and some old regulations to have the use monitor. So required an IRB. IRBs have HDE protocols. The use of our chronic device is not IRB dependent. The new device does not require any IRB. Presently, it's FDA approved, as FDA authorization for this pandemic. So it's authorized for use, and you can actually place this without an IRB. Somebody asked, if this device is temporary, what if it's needed for more than 30 days? We would hope that most patients with the use of diaphragm pacing would not require that. What we believe is if you have a spinal cord injured patient, I would place the chronic system. So most hospitals would be able to get emergency approval for the chronic system, and that's what I'd place. The question that goes along with this, Dr. Kaufman brought up, is could you replace this with a chronic system? On that one case I showed you with the elevated right diaphragm, we believe that that patient, I got him off the ventilator in this acute emergency center, and to discuss chronic or nerve reconstruction, which requires a chronic system, I may, as we get him out from his aortic aneurysm problem and his acute event, we may convert him to a chronic system. A unilateral elevated diaphragm, which I was going to present a large series at the ATS meeting this in May, requires a chronic system. So yes, I could convert it to the chronic system if needed. I would think that most patients that we're going to use this in the ICU would just use a temporary system. If you have an injured nerve or if you're a spinal cord injured patient, you should implant the chronic system if you can. Now, at times, in talking to my own trauma surgeons and other trauma surgeons, you may have that multiply injured patient that needs that laparotomy, has a spinal cord injury. You don't know what level he is because that need to take out the spleen. And as we all know, in these unfortunate cases, that they may require both, is you can place the temporary system, then assess the patient. You get them through that initial hospital course, putting in that system during a laparotomy, and then assessing if they need the chronic system because they can't breathe on their own, but they can breathe TransAeris. I would convert it to chronic system at that point in time. That conversion should be pretty straightforward in these patients. They would be used to the device. Another question was, can we use the new electrodes with the chronic system? No, and this is for two reasons. One, the electrodes, again, we are designed this electrode to be able to be removed. And so my concern with using it chronically would be that the electrodes may fall out. So I have very good data on our chronic system that we've had patients using the same electrode for a number of years. Therefore, I know that system can last for that patient's life, but I don't know for this system. Also, we have the problem is that in our chronic system, we have to tunnel the electrodes to a central location and then plant a ground electrode. The other benefit for those familiar with our chronic system is, as you can see on this, there's two connections. Maybe I didn't show it well. So I don't need to tunnel them. I check it on both sides. The connector piece has a patch. There's no ground wire to place. The patch acts as the ground wire for these patients. So the chronic system requires that little bit more. It's a little bit better system that I know after using it for 20 years would work for those patients. The ballpark cost. The electrodes, I believe, are about $100 a piece. Again, I don't know the exact cost for this. The difference in price is significantly much lower for that extra device. This is something that's significantly less expensive than our chronic device. I'm checking to make sure if I'm missing some other chat questions. I'm sorry if somebody's using the chat one as opposed to the question and answer box. On my control, I can't see the chat quite well. I think John Sikora had texted me a chat. But if you see the question and answer section, I can see that and talk with that. So I apologize if somebody's using the chat section of it. There's some other questions that come out. The question is there a company support for the first implants? And we do believe, as we all know, and this is something that we'll be addressing, is that with the travel ban and everything, it'll be hard, but I've worked very closely on OR Live and doing literally with, I've helped implant the first cases in Toronto purely with Facebook and OR Live. So because this is fairly easy to implant and fairly easy to work, we believe that we can actually train surgeons at the time of operation. As you saw from these videos, placing these electrodes is pretty standard laparoscopically, laparotomy. Using an external device we could do live chats with or live interactions. We've shown, and we're actually working for a SAGES grant that confirmed that we can actually train people on using this to do live interactions such as this, more of a Zoom call where I can see you and you can see me. So that's what we believe will help for these patients. I'm looking for any other questions. And again, if I'm gonna put my email is right on the bottom here. So if you email me any questions, I'd be happy to answer them. I can send my slides to you. So my email is raymond.onders@uhhospitals.org. There's another question that occurred here, is that a patient that's still COVID positive and is 3 weeks on a ventilator. And this is where I think we all know, my state of Ohio, we're going to start opening up elective surgeries because we've not been hit too bad. And I know in our own practices is that if I'm going to do laparoscopy that involves an intubation or an upper endoscopy, we're checking COVID positive, if they're COVID positive or not on every patient. We believe we'll be able to do that in the next 2 weeks when we open up surgery in May in our state of Ohio. If somebody's still COVID positive, we do know that nobody will do a tracheostomy on that patient. The question comes up is, would we do laparoscopy on that patient? And I think as we all look at the risk for laparoscopy, I think there may be aerosolization. There'll become that question on what is safer for these patients. Is doing the laparoscopy to try to get them off the ventilator versus a tracheostomy if they need it. If it's been 3 to 4 weeks, we're kind of waiting to see if we can get them until they're COVID negative. We know surgery may be a little bit safer. We have operated on COVID positive patients here. We all take all of our precautions for these patients and simplify everything. As we all say in academic, any COVID positive patient is not a teaching case anymore. It's placing these electrodes fairly rapidly. I think we'll get more knowledge about that in the future. So I think we're still looking at when we place these in COVID positive patients. Again, I'm sorry if somebody's trying to chat with me, but I just cannot get that on my screen. Any other questions? Again, I thank all of you for coming on the board here. I think as we all realize that we are realizing how important it is to get patients off the ventilator. Obviously, it's working on this for 20 years, my entire career, trying to get patients off the ventilator. Trying to get more patients off the ventilator now is very important. Hopefully, I can answer any of the questions. This will help other patients. We'll gain more information as we go forward. So at this point in time, I'll at least I'll hang out here if everybody has any other questions, or I can go over slides if someone would ask the question and answer aspect. Otherwise, feel free to just email any questions to me or contact Synapse Biomedical, which has been critically involved in helping to provide this technology to patients really throughout the world. I hope everybody's staying safe and in all of your locations. I see friends of mine that I've worked with over the years, Dr. Duco in Boston, Dr. Diebel, and which is Detroit's a hard-hit area right now. Dr. Lautenberg, the groups in Florida have been very active in utilizing this over the years. And again, Dr. Kaufman is really just phenomenal in helping with the nerve transfers and our data and helping many patients even prior to this.